Hi everybody, and I am back. And this time I would be talking about knee pain. Now, how do I plan to conduct this talk is rather than going through the boring stuff of anatomy, clinical examination, and blah blah blah, I have kept it interesting. I would be carrying forward the discussion through a series of cases. Again, these are very common cases that we come across in our day-to-day chronic pain OPDs. I'll be going from the not so common to not so common back again. And as you all know, you will have my number and my email. So get back to me if you have any doubt. So let us start with the first case. So we have a 35-year-old female patient complains of bilateral knee pain. Now, important thing, it's a bilateral pain. Along with that, it is of sudden onset, no history of injuries, and two things which make it interesting is that the patient is also complaining of small joint pains and early morning stiffness. So whenever we get any small joint pains along with knee pain, what we are dealing with is not probably that we see commonly. That is probably what you call it as autoimmune arthritis, or in this case, rheumatoid arthritis. Fine. So how do we diagnose rheumatoid arthritis? Now, it is very simple. These criteria are given by ACR, which is the American College of Rheumatology, as well as European Union Against Rheumatism. So what they have done is they have divided it into 4 categories. Now, these 4 categories are again divided into 2 categories. One are clinical things. Second is lab things, laboratory things. So what are these clinical things? Now, these clinical things are basically joints. Now, important thing which I talked about even just in the previous slide was that in rheumatoid arthritis, importance is given to smaller joints. Therefore, this diagnosing criteria works on this number system. This gets the point system. So here, if you look at it, major points are given to the smaller joints. Okay. So firstly, there is joint, and secondly, in history, what is the duration? Are we looking at acute kind of a setting which is less than 6 weeks, or which is greater than equal to 6 weeks? So greater than equal to 6 weeks carries more weightage. So based on the joint distribution, based on the duration, you get points. Then for the lab investigations, you have 2 things. Firstly, which is serology. In serology, there are 2 important things which we need to look into. One is a RA factor, which is not so specific. The specific test is the anti-CCP factor. So whenever you are ordering, you order for RA factor and anti-CCP. Along with that, we also try to diagnose the acute phase reactants. When we talk about acute phase reactants, we talk about CRP and ESR. So we take the history, we talk about the duration, and then we talk about the serology, RA factor, anti-CCP, and then the acute phase reactants where we have the CRP and the ESR. We sum it all up, and if the number is greater than equal to 6, then it is definitive rheumatoid arthritis. Now, one important thing is that we should also understand is, now this 6, we can get this 6 in both ways, prospectively and retrospectively. Retrospectively means that in the previous records or in the previous history, if the patient comes to us whose ESR or CRP was positive at some time, or his history is some joint problem in the past, and now his ER and CRP are positive, and now sum is greater than 6, then also we can label it as rheumatoid arthritis. The same goes, probably some tests are positive now, some things will come positive later, then also the patient can have rheumatoid arthritis. How do we treat them? Now, when we talk about treating them, firstly, the NSAIDs is the first line of treatment. Now, this has to be explained to the patient that your treatment is going to work on 2 lines. Now, the first line is where I am taking care of your symptoms. The second line is something where I am taking care of your disease status. So what do we do? For symptom wise, we go for NSAIDs. Along with that, sometimes we add muscle relaxants also. And for the other thing, what we do is we start using DMARDs, which is disease modifying anti-rheumatic drugs. Most commonly used are methotrexate, hydroxychloroquine, sulfasalazine, and lefenamide. And this is the entire list. Now, along with that, not very recently, but yes, in the past 5 to 6 years, there has been an influx of a lot of biologicals, which are more specific, which can bring down the immunity of the patient for a very long time. And gradually, we have started using them in our day-to-day practice. Now, this is also one thing which we can use. Now, this restrictive club of DMRDs, there was recent addition of igrutimod. So now this is the first line drug which can be used as a monotherapy in ankylosing spondylitis, whereas in rheumatoid arthritis, it is used as a dual therapy along with methotrexate. Role of glucocorticoids. Now, this is something which we are often asked: what is the role of what is the role of glucocorticoids in rheumatoid arthritis? Are we over prescribing? Are we under prescribing? Should we prescribe or should we not prescribe? Now, the answer to that is: see, the thing is, what we are dealing with is an inflammatory condition, right? So, if we are dealing with an inflammatory condition, we have to use an anti-inflammatory. And what is the most potent anti-inflammatory that we know is corticosteroids. So yes, we can use corticosteroids, especially when we are managing acute flare-up. There is a lot of pain, polyarthralgia, patient is in pain. You give glucocorticoids. How do we do? We start with low dose and then we gradually increase it. That is one. Second thing is, there is also few studies which have come up that where we are giving low dose corticosteroids for a very long time just to prevent the deformities. Be rest assured that for small dose given over a longer period will not disturb HPA axis too much. So don't be worried about it. And small doses, small bursts of steroids given to manage acute flare-up again will not result in any problem with the HPA axis. So use them judiciously, but do not hesitate to use them. Now, again, I will not be going because of the time constraints, but again, one thing which can mimic rheumatoid arthritis is gout. Though these things are rare, but yes, based on the cultural, the dietary habits, you can come across a lot of patients who come to you with knee pain, but they actually suffer from conditions like gout and rheumatoid arthritis. Now, let us move towards the common thing. I feel and I hope that the number one sport in your part of the world is soccer, football. So this was one patient. We are not so good in it. So, but still there are some amateur leagues which are running around, which we play around. So a professional football player comes with a severe knee pain with swelling, which was during the pain. Now, important point is that there was no contact. So the patient had knee pain along with swelling, but there was no contact. He was just trying to get the ball. He took a sudden turn on his knee, and because of that sudden turn in the knee, there was swelling and pain. How do we approach? Now, these are the things which we come across. How do we approach these patients and time the investigations? So during this next 5 minutes, I'll be talking briefly about them. So before this happens, most important, let us try to get the anatomy. Now that will help us find out which part is weak. See, now this is an injury. So before we find out how do we treat them, we have to be very sure about what is the part which has been injured, right? Okay, so before going into the greater details, so basically the knee joint is formed from 3 bones: tibia, femur, and the patella. Then to hold them together, you have the ACL and the PCL, which is the anterior cruciate ligament, and then we have the posterior cruciate ligament. To move them to act as a cushion, you have the menisci. Then to the outside, we have the collateral ligaments. So ACL, PCL, the menisci, right? And just to make the motions easy, you have a lot of these bursas. Bursas are nothing but fluid-filled cavities. Their job is to make the motion simple. Now, why are these bursas important? Because if there is an overuse of that part, if there is a lot of friction in these areas, these bursas have a tendency of inflaming. They will get inflamed and they will get painful, and the patient will have pain in that particular area. So you have a prepatellar. So that is again very important, is which I have seen sometimes doctors tend to ignore, is we try to always try to find the answer within the knee joint. It is not sometimes within the knee joint. It can be around the knee joint also. Therefore, the site becomes most important, and that will help us clinch the diagnosis. For example, you have the suprapatellar bursa, which is above the knee joint. Then just in front of the patella, you have the prepatellar bursa, the infrapatellar bursa, and pes and serine bursa. Right? So this is a diagram which talks about that specific pain. So knee per se can be painful, then area around the knee can be painful, and just based on the area which is painful, you can diagnose that what particular organ, structure, bursa might have been involved. Right? Okay. Now, interestingly, we talk about menisci. Now, menisci, interestingly, has got its blood supply coming from the outside and moving in, right? So you just imagine you have an area of the menisci where you can appreciate. I really want you to concentrate here. The blood supply is coming from the outside and going towards inside. So this part of the menisci, which will have rich vascular supply, this will have restricted vascular supply, and this part will have no blood supply. Right? So you can appreciate in this section, you have the red zone, which is good with vascularity. Then you have the pink zone, which has got poor vascularity. And then you have the white zone, which has got no vascularity. Now, why it is important for us pain physicians? See, the thing is, if there is an injury, if there is a tear in the red zone, there is a possibility that it will recover either by conservative management or by our interventional management. I repeat, red zone is a good vascular zone. So if there is an injury in the red zone, in any sort of a tear in the red zone, then your patient will recover and you will be able to help the patient. If it is in the pink zone, may or may not recover. In the white zone, it is not going to recover. So if there is a tear which involves the white zone, the patient either you do nothing, patient recovers, may or may not, or the patient is comfortable with the handicap if his lifestyle demands so, or if the patient is active, playing professional sports, then the patient requires surgery to take it out. So this has to be extremely clear, and this is something, because we will be talking about regenerative options, we will be talking about PRPs, and where does it going to work? It is going to work if there is a lesion in the red zone. Lesion in the red zone has got a blood supply and chances of recovery. Now this can be, now this is the menisci. So it can be like this lesion, or lesion can be sliced like this. Right? And we have talked about the ACL and the PCL, the anterior cruciate ligament, starts from the tibia and goes back. So this is like a cross, which holds the tibia and the femur straight so that they work synchronously as a single unit. Right? Now, these are few things which will help you clinch the diagnosis. Non-contact injury with a pop is an ACL. Contact injury with a pop is a medial collateral, lateral collateral, meniscal tear. Acute swelling. Now, this is important. See, the thing is, ACLs are quite vascular structures. So if there is a damage to the ACL, whether it is the anterior cruciate ligament or the posterior cruciate ligament, then there is going to be a lot of swelling, a lot of edema, a lot of blood, which is going to be there in the joint, which will call it to swell up. Fine. Then some things are based anatomically. So if there is an impact on the medial aspect, so the lateral part of the joint, the lateral part of the joint will be stretched. So therefore, there might be damage to the lateral compartment. In the same, if there is a lateral blow, the medial compartment will go. Buckling or give way is something which is there with the ACL, and fall on the flex is PCL. So before my friends who celebrate like Ronaldo going on their knees to celebrate a goal, remember you are putting your PCL at risk of being torn. Now, unhappy triad. Why it is unhappy? Because the chances of recovery are less. So what happens is that if you have, now one more important thing is when we talk about menisci, the medial menisci is tightly attached to the tibia, because of which there is hardly any movement of the tibia. So what happens is whenever there is an injury on the medial aspect, therefore, along with the MCL, the medial collateral will also go. So you have anterior cruciate ligament going, MECL tear going, and meniscal tear. Now this is bad for you. This is bad for you. Now this is something that we come across, and the patient that we discussed actually had this. Now success will depend upon whether we are dealing with partial tear or we are dealing with incomplete or we are dealing with when it comes down to menisci, which part of the menisci, the red zone, the white, pink zone, or the white zone. So all this will decide upon this. These are few clues about it. Now, how do we do? So firstly, this is how do we examine it. Simple things like gait, swelling, redness, scar, muscle wasting, and deformity. Now, muscle wasting can be there most commonly in patients of long-standing knee pain who have just stopped using their quadriceps, seen in osteoarthritis, and deformity is also seen. So these are the this diagram will give you an idea about the structural anatomy of this. Now, what do we palpate it? We palpate the temperature, tenderness of the joint line. Now, tenderness is extremely important, and this is what we discussed when I was trying to discuss about the anatomy also. Key tenderness will give you an idea about the diagnosis of what we are trying to do, what has gone wrong, which bursa has gone wrong, which tendon has gone wrong, which menisci has been torn. So that will give you an idea. Medial, you have the medial joint line pain, medial menisci. Medial pain on the medial aspect of the knee is a medial collateral ligament. Above the patella, you have the prepatellar bursa. So all these things will give you an eye, effusion and range of motion. Now, this is what I was trying to say, that lateral joint line and lateral collateral ligament, medial collateral ligament, medial joint line, and pes and serine bursa. Now, how do we do it? Now, this is something which comes with experience. So basically what we are trying to do is we are trying to collect and find out whether there is any sort of joint effusion or not. First thing is palpate the boundaries of the patella. If you are able to palpate, it is fine. If you are not, then probably you are dealing with some sort of an effusion. How do we do it? So this is an allotment test in which you can see that we try to milk the fluid on one part, collect it, and then palpate it if it is ballotable or not. Range of motion. Normally the movement of the knee is in one direction, flexion and extension. So flexion is not complete. It is around, the range is 0 to 135. Minimum rotation around 20 to 30 degrees is there. So try to see whether this kind of a deformity is there or not. Now, these are specific tests which we go for ACL, PCL, collateral ligament, and menisci. I wish I could have gone into the detail because of time constraints. I couldn't, but yes, these are specific tests which will give you an idea. Now, before we go into this test, few basic rule of thumb. Firstly, if there is an acute, inflamed, painful knee, please don't do it. Let the pain and acute inflammation settle down. That is one. Second thing is, this will give you an idea. But for me, if I have to manage my patients and do an intervention or suggest an intervention to that patients, I will definitely need a MRI to support my findings. So therefore, this will give an idea, but final is the MRI. Now we get an MRI done. Suppose we get a partial tear or we might get a complete tear. My dear, complete tear definitely requires a surgery and the patient should be given that option. When it comes down to partial tears, yes, ACL, PCL, yes, medial lateral collateral ligaments, yes. But what do we do if we have menisci? Again, I'm repeating probably for the third time, always consider it. Now, because I've seen intervention being failed, if you do not consider which zone of the menisci are you actually dealing with, which is the red zone or the pink zone or the white zone. So you have good prognosis if you are dealing with the right zone. So this we have discussed. So now this will give you an idea. So these are different types of tear. White zone being involved, pink zone is being involved. Here maybe red and good prognosis. Again, white going up to here. This is a buckle handle. Again, white zone, not to be done. Fine. So once we know that, yes, there is partial tear, red zone is being involved, and we can definitely help the patient. So what do we do? What options do we have? Do we give steroids? No, we have moved on, my friends. We have moved on and we are now towards the regenerative medicine. So let us talk a bit about it. Though it's a separate topic, I will just be briefly touching about the basics of regenerative medicines, and then we will be coming down specific to my case. So basically in regenerative medicines, what we are using is we are using this, our tissue, our body's healing power, and just helping it get better. So what do we do? One is that we just take the cells without any processing and use them. That is what we are using for fat grafts, in which there is minimal manipulations and we are just injecting it. Second is cell concentrates. Now what we are doing is, in this, we are doing some sort of processing. Along with that, we are doing centrifugation. Fine. Now, based on that, the tissue that we are using, based on that tissue that we are using, we can have either have PRP, which is derived from blood. We can have BAMC, which is derived from bone marrow. And then we have the adipocytes giving us to SVF. Fine. So here you took it, minimally processed it and centrifuged it, and based on it we got these things. And most of the times, and most what we are doing here, or which has caught up in a big way, is the PRP, because it is least invasive. The tissue is just blood, which you can get very easily, and then you can do a centrifugation. Now moving on, when there is additional processing, what do we get is the mesenchymal stem cells. Now there are certain criteria which need to be fulfilled before a tissue can be categorized as mesenchymal stem cells. There are certain markers, cell surface markers, which have to be positive, like 104, 105, 73, and 90. Along with that, plastical adherence is required, and there are certain specifications because of which then we can label it as the mesenchymal cells. These are probably high quality regenerative options that we have. They divide into chondrocyte, adipocytes, and osteoblasts, and basically you can bring about a lot of changes in it. Now, let's talk about PRP, which we have. I have the largest experience in it, and we have been using it for 5-6 years now, though we have moved on from basic PRP to growth factor PRP and various things. Now, what is the basic challenge? What is basically PRP? PRP is platelet-rich plasma. So you take a plasma and increase the concentration of platelets by 4 to 5 means qualifies that solution to be called as platelet-rich plasma. Now, the biggest problem with PRP is there is no standardization. There are n number of kits, there are n number of machines which are doing it. So which is better, which is best, I don't want to get into that debate, but what I can tell you with surety is that whatever method you are using, if you are able to increase the concentration of platelets by 4 to 5 times, my friend, you have a good quality, decent quality PRP, and you can go ahead and do it. What we are using is, this is a REMI machine which we have, which is inbuilt in from India, and then we are using a Dr. PRP kit. So in Dr. PRP kit, we are using 18 ml of blood, 2 ml of ACD, centrifuge, which is a pre-cooled double centrifugation technique that we are using, in which we are using 1800 RPM and 3500 RPM, and then we get the good quality PRP. Now what we are using is the Buffy coat. And that is what we are injecting into the area. Now, what is the advantage? It is you are using the same blood, no sort of side effects, no allergies, no infections, no steroid related things. And especially, this is important. See, we are treating patients who are professional sports persons, who come under WADA, we come under doping. So this is absolutely safe. I have given patients to my own country's Olympic contingent, because we are not sure. Steroids, they have to get a permission, and there's a long process of it, and you have to be very sure it's not a working joint. So for any tendon, any joint, any ligament, you can use PRP. Absolutely no problem. Please go ahead and do it. Quick procedure, avoid surgery, early recovery. Risk of treatment, very low. Allergic, maybe. Risk of infection, very less. Now, important thing is, which I always tell is, see, the thing is, when the patient is doing PRP, they are not supposed to take anything which will stop the chemical reaction of healing. And one of them is platelets, one of them is Medrol or steroids, and the other one is what you call it as NSAIDs. So the patient is not supposed to do any sort of painkiller. He can take milder forms of opioid, which are to be safe. Now, this is something very, very, very important while you are prescribing. No painkillers. Fine. So what we do in this is, once we know this is what we call it as a patient has an acute injury, let the acute injury settle down, get the examination done, try to find out based on the surface anatomy what area is being involved. We get the scan done, try to correlate, pinpoint, and then we do the PRP. How do we do it? We always do it under image guidance. We will be talking about it very soon. Now, this is again a very common patient. Most common after spine that we come across is a lot of old age female patient, pain having cross-leg sitting, squatting, causing pain, climbing up or down the stairs, causing pain. It is happening. It is hampering her day-to-day quality. So, and no abnormality detected. So, what are we dealing with? How do we this? So, what we are dealing with basically is intra-aortic osteoarthritis. Again, very common. So, how do we approach? I'll be talking about these aspects. So osteoarthritis, again, very common, and most of with the increased obesity, sedentary lifestyle, and all those things, lack of exercise, most of us are predisposing ourselves to this problem one day or the other. So as I told you, what are the associated risk factors? There is obesity, sedentary lifestyle, life patterns, diet, prior injury. Now that is one thing which I always, patients always ask me, sir, what will happen if I have a ligamental injury? So I only tell them that make sure that your weight doesn't increase, make sure that you have good muscle strength, because what will eventually lead to is that prior injury will progress and lead to this early onset osteoarthritis. Now, okay, fine. How do we diagnose and how do we grade osteoarthritis? Now, there is a gold standard thing that we are using. We are using basically two systems. One is based on the investigation, that is an X-ray. Now, X-ray has to be taken in an AP view in a standing position or a weight-bearing position. So there, based on that, we label it as grade 1, grade 2, grade 3, or grade 4, which is mild, moderate, and severe. Fine. Along with that, which often I have seen people ignore, is that they just try to look at the scans. When you treat patients of pain, always try to ask, what is the impact of this pain on your quality of life? Now, this I can't emphasize enough. You have to understand that the quality of life will be different for a 75-year-old person versus a 65-year-old person versus a 45-year-old person versus a 25-year-old person versus a 25-year-old person who is competing in a sport at the highest level. So their impact is different. So to take care of that, we have this WOMAC score, which is specific to osteoarthritis, but it helps us both while managing this patient, planning an intervention, as well as seeing the impact of these things. What is the impact? What is the outcome of our interventions? So always consider both these things when you are thinking. So these are basically questions, around 24 questions, which talk about the various aspects: pain, stiffness, and function. Major thing about function. So whenever you are assessing, so you have the KL scale and then you have the WOMAC scale. Now, managing osteoarthritis, exercise, weight loss, you have to emphasize on these aspects, because when the patients turn up to doctors, they think about magical pills that you will just do something like an Harry Potter and things will just vanish. It's not going to happen. We are in this journey together, me and my patient, and both have to work equally hard if we want an improved quality of life. Fine. Drugs, we have discussed, not NSAIDs. Most of the times, these NSAIDs you will not like to continue for a long time. You can consider going weak opioids. I would not be comfortable in strong opioids. Hot and cold fermentation, patients, and onwards. So, talk about interventions. Now, something which I called as a sniper theory. Most of you, or some of you, I think most of you, some point of time would have played some sort of a video game, a war sort of a video game where you are taking shots. Now, broadly speaking, there are two kinds of shots or two kinds of guns that you can use. One is a sniper shot, where you aim, target, and bam. Second is an assault rifle, where you don't aim, you just fire. Ta, 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 ta. Pain medicine is all about taking that sniper shot. You identify the target, you aim at the target, and then you deliver the deadly blow. So whatever interventions that we discuss, always have to be precise. That is what separates us from the other people doing intervention. If you want to practice good pain medicine, you have to be precise. And that is why all interventions have to be image guided. Fine. So let us talk about these knee interventions. So knee is like this room. So you can enter this room through the door, through the window, through the ventilator, or I can break the wall and come in. So the same way, this is your knee. You can appreciate this is your patella, and you can go supralateral, infralateral, supromedial, and inframedial, right? Anyway, right? So this is again patella, and you can go inframedial, infralateral, right? Now, this is the interventions that we have done fluoro-guided, fluoroscopic. You can appreciate it. This is the joint, and we have introduced the needle. And how do we confirm? By putting in the dye. Now, coming back to the sniper shot, we want to be doubly sure that we are in. So how do we do it? Firstly, we go it under image. We can do it under ultrasound also. Sorry, I don't have that image, but yeah, you can go under ultrasound, and you can take out some synovial fluid also, so that you are sure that you are inside the joint. So that is what the sniper theory is all about. Multiple ways to confirm your target that you are inside the joint, because this is what we do, right? So you go inside the joint by AP view, lateral view, confirm it with the dye, and then you take out the synovial fluid. Now this is something which is unique. I can say that I have tried to pioneer it. I've still done around 5 cases where in some patients, because I was combining a spine in this, the patient could not be in a prone position. Those things were done in, this was done in supine position. This was done in a prone position. So you can again see the needle placement and the dye spread. Fine. I will be again more than happy to answer any of these questions regarding my technique with the details of my WhatsApp and mail to you. Now moving on to the effects of corticosteroids. Now there has been a lot of apprehensions about it, and rightly so, that because there were studies which talked about the cartilage damage associated with use of corticosteroids, and it is not unwarranted. There are studies which talk about that you can accelerate osteoarthritis when we use corticosteroids. But this was a very interesting systematic review in which they talked about, yes, it can cause, but still steroids are beneficial. And if we want to use them, we can use a low dose steroid of a shorter acting duration. Fine. Viscosupplementation, honestly, not a big fan, but yes, we can consider using it in early stages of osteoarthritis. This is what I feel. This is our take. That's why I have said not a big fan of viscosupplementation. Secondly, these kind of patients turn up because most of the patients that turn up to my OPD are already in grade 3 and grade 4, where it has got limited effect. Some studies are there of combining two things like steroid and viscosupplementation. I am sort of a purist, so if you have chosen one thing, stick to it. Now, regarding stem cells, this is also which is often asked, what is the theory behind or what is the data behind it? Now, this was a good, which came in British Journal of Sports Medicine in 2017, August, where they said that a lot of studies were there and they talked about, yes, they are beneficial. Stem cell injections are beneficial, but the biggest problem was that there was a lot of bias. That is one. Secondly, there was no standardization. And without standardization, you cannot do good quality studies. So that is a big problem when we try to compare. So standardization is something which we strive for. Now, this is our derived data with regards to PRP. I don't know how much PRP is popular in your wonderful country. So this is what I can share with you. This is based on our own derived data. We have audited it. That's generally what we do. So this is what we did. And what we found out was, yes, for smaller joints, it is wonderful. For smaller tendinopathies, it is wonderful. You can appreciate non-weight bearing, it is wonderful. Something like a shoulder, elbow, foot and ankle, it is phenomenal. Knee, good for tendinopathy, but not good for osteoarthritis. Hip, many might say why. There was a lot of failure. The reason was we did it in AVN, and in AVN the prognosis is not that great. And anyway, it's a weight bearing joint. So both these things not a good thing. So what are these studies or the guidelines they talked about is hyaluronic acid. See, the thing is, orthopedicians they have not been very happy with that. Osteoarthritis, both again, it comes down to hyaluronic and glucocorticoids. So basically, what they talk about is glucocorticoids are definitely recommended throughout the organizations. When again to ACR, now it is a rheumatological organization, and stem cells PRP, they have said not to be used because of lack of standardization. So this is something which I need to discuss. And as a community, if we want to grow, we have to have standard practices of some sort so that it can come into the natural practice. Strongly recommend. We have already discussed exercise, weight loss, brace, and NSAIDs, provided there are no contraindications. Conditionally approved is radiofrequency ablation. This is the last thing that I'll be talking about. Against is hyaluronic acid. Again, this was ACR. Hyaluronic acid is not there. We are just wasting money on the patient. Prolotherapy modifies non-tramadol opioids and vitamin D. Corticosteroids, which we have already discussed. Now, this was something which people who have listened to my neuropathic pain will say, this is a repetition of it, where I talked about it. For a very long time, osteoarthritic pain was considered to be a pure nociceptive pain, but now we have studies both done at different institutes and even at our institute, where we found out that there is a component of neuropathic pain in osteoarthritis knee, and as doctors, we should be able to diagnose it and treat it if we really want our interventions to succeed. And it is very simple. Starting a small neuropathic agent, this is all what we need. So this was again our data which we shared or presented at World Congress. Now, last question, where we have a 70-year-old patient, deformities there, grade 4 osteoarthritic knee, but as you can see, CRF, ejection fraction 25, an extremely high risk candidate for surgery. And these kind of patients, even the surgeons would not be comfortable. So what do we do next? See, I'll take just 2 minutes. Most of us pain physicians come from anesthesia background, who have got their basic postgraduate training in anesthesia. And anesthesia, we always have that love affair with nerves. We love nerves and we love blocking them. So now this is the time where we ignite that our old romance of, for me, around 12, 15 years back when I was doing my residency, and bring it back and block the nerve. So what nerves are there? Now, these are certain genicular nerves. Their only job in this world is to supply the sensory part of the joint, right? They only provide sensory supply or sensory innervation to the knee. So what do? We block them. And God Almighty has made our job easy to bring an artery close to it. Secondly, they are close to the bone. Bone is our friend when we are doing interventions in fluoroscopy. Sniper theory. The same thing, artery becomes our friend when we are doing these interventions under ultrasound, right? So again, the sniper theory, you have to do it under imaging, either fluoro or ultrasound. Both are more or less equal. Now studies are there, but with fluoroscopy, bones becomes our landmark. When ultrasound, artery becomes our landmark. So you can appreciate that these are the arteries and these are the nerves. Artery, very close to the artery is the nerve. Artery, you can close to the nerve, right? Now, when it comes down to fluoroscopy, these are the nerves, supralateral, supramedial, and inframedial. These three nerves supply more than 70% of the articular surface of the knee, and blocking these nerves bring about good relief. Now, this is the positioning of the needles. This is an AP position and lateral. Again, sniper, you have to confirm in multiple view because you have to give the most potent drug. Cooled and standard. Now, initially we were standard. Now we are moving towards cool. Money is definitely a criteria because of the cost involved. But yes, cooled promises to give us a lot of larger size lesions. And my own experience is almost right now, both of them are equal. I did my first cool tip RF case around 4 years back, and standard RF has I have been doing for now 8 or 9 years. So more or less, they are giving me similar results. So still not totally convinced to shift to cool tip RF considering the cost. Now, this are few things before I wind up. Now, there is a very small subset of patients who says that post TKR, post their knee replacement, they have this pain, which we call it the post-surgical pain. Now, this is there. And these patients are very challenging to manage, because they have undergone a surgery just because of this pain, and now the pain continues to trouble them. In that case, sometimes there are a lot of possible diagnoses. One can be that the patient is having scar neuralgia, take care of that. Or the patient can have a neuropathic pain, which was ignored during the procedure or pre or post procedure. And third is that patient can be having a spine pain coming down, and then there are other deformities. So, but be aware of that. Now, again, one thing which I am using a lot is a ozone therapy, in which we are injecting intra-articular ozone along with oxygen. Good results. These are some studies to prove it. See, the technique becomes same. So be assured, whether you are putting in steroid, whether I am putting in oxygen or ozone mixture, or whether I am doing PRP. Now, the technique of doing it under fluoroscopy or ultrasound remains the same. Fine. Now, dextrose prolotherapy is something, again, which is not tried in the lesser developed world. Good. I am not comfortable putting dextrose inside the joint, but sometimes if the patient is not able to afford RFA, I have done it in a few cases. Now, interestingly, now this is something which I would just like to leave before I say a final goodbye on this topic: role of placebo. Now, this was a study which came out in 2017 in American Journal of Sport Medicine, where they said that the effect of intra-articular normal saline injection used as a placebo did bring about significant pain relief up to 6 months after the procedure. So this gives you a thought that you think that, okay, probably my steroid is working. Somebody might think my ozone is working. Somebody might think and hyaluronic acid is working. But is it really working? Or is just the power of that placebo or that needle being put in the knee joint? With that school of thought, I would say a bye-bye and just give you an overall: hyaluronic acid, use glucocorticosteroids, definitely a role. Take small doses. Hyaluronic acid, limited use, initial part. Third is PRP, coming up in a big way, avoids a lot of surgeries, improved functionality, natural thing. Try to standardize it, get some articles from your own country, and so that we can make it more streamlined. RFA, or radiofrequency ablation of the genicular nerve, please, my dear friends, is reserved only for grade 4 deformities or patients who do not want to get surgery for some reasons. So try to reserve it. And again, going slightly beyond the topic, is that it is a 2-stage procedure. Whenever you are doing any ablative procedure, you first block the nerve, see the effect. If the patient is having more than 50%, then only we go for an RF ablation. So initially, the first step is just the diagnostic block. So once the diagnostic block gives effect, that is one. And where I would just like to end from where I started, that though we come across more of injuries, more of degenerative changes, but still rheumatoid and gout is something which can be there. So be aware of it. With that, again, the confidence that I have, more than happy to welcome you. I'm not sure how the COVID is going to be there, but we will try an online option also. And this is my number. Please feel free to get in touch with anything, any technique, anything you want to talk and discuss. With that, I will say thank you.